Hello, Insta family. It is Dr. T coming to you on Wednesday night for our live Q&A. I have managed to get through to the second week of the school holidays somewhat unscathed. It has been, I have heard my mother occasionally coming out of my mouth when my kids have said, I'm bored. And my answer was, boring people are bored. So go find something to do. But we've managed to get here relatively unharmed, and we're rolling down to term 4. But I thought I would jump on here and do a little live Q&A. So as usual, if you have any thoughts or questions to ask, please pop them into the comment section below. Well, please, we don't need your whole life story. I will only be giving generic answers. I'm not going to answer your medical issues. I will always encourage you to go back and chat to your doctor or your fertility specialist. This is not really the place to be making diagnoses, but certainly it is a place to be sharing general information. And that's my mission, that's my purpose. I know that it is hard to find accurate, truthful, trustworthy information on social media and in the digital space. And so I want to make sure that the information that you are receiving is evidence-based and will help you to make informed decisions about your health and fertility moving forward. So yes, if you do have anything to ask, please drop it into the comments section while we're chatting. Now, many of you will have noticed that on my Instagram, I have been asking you lots of questions lately. And I was kind of hoping for a few more answers to these questions than I've had. So I am going to pose them here. And I would like you to go back to the posts. I have pinned them to the top of my Instagram feed. And so you'll see 3 questions. I would really, really love your input into this. This is really important so that we can help to serve you in the best way possible. So question number 1 is, what social media platform do you tend to go to for your information about women's health, gynecology and fertility? That's the first question. The second one is, who is your go-to, influencer in the fertility and women's healthcare space? I want to know who you're following and who you get your information from. And I also want to know how often you are going to social media platforms to find your information. Sort of, is it hourly? Is it daily? Is it weekly? Is it once in a blue moon? Because this is really important for us to be able to optimally use these platforms to give you the best experience when it comes to gathering information that's evidence-based around reproductive health and fertility. So if you could help us out, and if you could ask all of your friends to be going to the pinned posts that are at the top of my Instagram feed and helping us glean this information from our community. Now, I have seen a couple of questions that have been dropped in since I've been chatting away. Let me scroll back through. C.L. Gibson, PCOS ovulation induction, how many rounds before you try something else? Okay. So if someone has disordered ovulation, as many women who have PCOS do, and there are other conditions that can lead to disordered ovulation as well, it's hard to know when you ovulate. So therefore, it's hard to know when to time intercourse. But not only that, when you have disordered ovulation, if the front half of that cycle before you ovulate is a bit iffy, and the follicle is not quite growing correctly because the information that it's receiving from the brain is a little bit out of whack, then often the luteal phase, when an embryo is trying to implant into the lining, in that window of implantation is often not normal too. And so ovulation induction, where we make you ovulate 1 or maybe 2 follicles, and then you time intercourse, is the right kind of treatment for someone who has disordered ovulation or anovulatory infertility. It used to be that we would say, just keep going, because all we're trying to do is bring you back to the background chance at your age of trying to conceive. And if we look at fecundity across the entire population, it's about 20%. So each person has about a 20% chance of conceiving if they time intercourse around ovulation every month. So we're actually not a very good reproductive species anyway. Now, my rule of thumb, and it's not dogma, but it's my rule of thumb, is once you're getting to about 3 or 4 ovulatory cycles, so we've actually made you ovulate, and you're not conceiving, and we've proven the tubes are open, and we've confirmed that the male fertility is normal, so semen analysis is normal, then I think it is reasonable to sit down and consider moving on to some sort of more involved treatment. And the reason for that is that perhaps part of the reason why you've not conceived is an ovulation, but there could be something else going on. And the one thing about ovulation induction is we don't actually get to see if the sperm fertilizes the egg. We don't get to see the egg quality. We don't get to see how the egg and sperm interact with each other. We don't get to see the quality of the embryos created, and we don't get to see what happens when we put a good quality embryo into a cavity. So all these unanswered questions there. So for me, my rule of thumb is once we get to about 3 or 4 good ovulation induction cycles and you've not conceived, I think it's really reasonable to move on. So hopefully that helps to give you a little bit of guidance. Teg Ann, hello, how does stage 4 endo typically affect an IVF cycle after a lap? Gosh, there's so many variables in that question. Where was the endometriosis? Did it involve the ovaries? Was it optimally resected at the laparoscopy? Perhaps it was suboptimally resected. The one clear piece of knowledge that I can share with you is if somebody has stage 4 endometriosis and the thing that they're seeking is fertility, then laparoscopic removal of that endometriosis is not necessarily going to improve pregnancy rates in stage 4 endometriosis. In lesser stages, below stage 2, yes, it will increase the chances of spontaneous ovulation in the ensuing 6 months. But when you're dealing with severe endometriosis, it's often challenging to think that you have maximally resected it. I certainly, if you've got stage 4, would be seeing an advanced laparoscopic surgeon. But often there needs to be some sort of medical intervention after that point to optimize pregnancy rates from IVF. So I'm hoping that just might help direct your questioning in moving forward. Can you do IVF straight after laparoscopic excision of endo? Absolutely. It is a great time to create embryos, but not necessarily to put those embryos back. I do think there a discussion around should there be some medical downregulation of any residual disease. That's certainly how I approach it with my patients. Mrs. English Lady, lovely to have you on. Always enjoy your questions. For a day 2 fresh embryo transfer, when is implantation likely to occur? What symptoms do you look out for? So the window of implantation for every embryo is exactly the same. And that is day 6 to day 10 after ovulation, or day 7 to 11 after your LH surge, because we know that ovulation happens 12 to 24 hours after your LH surge. So if it's 7 to 11 days after you surge your LH, so you're having your egg collection 2 days after your LH surge or your trigger at 36 hours-ish, then you're creating an embryo, and then it's on day 2. it's really going to be at the point of being ready to implant once it reaches that blastocyst, which is still day 5. So there's still 3 days that the embryo will sit in the cavity and develop, if it's continuing to develop, before it will actually implant into the endometrium. Now, there's huge conjecture, argument, discussion, equipoise around, is it better to put embryos back into the cavity early because then they're in the physiological incubator versus incubating them in an incubator till day 5 and then putting them back in during the window of implantation. It is the belief of most people around the world that a extended culture, so day 5, day 6, when the embryo is at blastocyst stage, yields better pregnancy rates per embryo transfer. And the reason for that is that many day 2, day 3 embryos will just succumb. And you won't know that because you've transferred it. Whereas if you just cultured it, it wouldn't have even reached blastocyst, so it wouldn't ever have got to a transfer. But the other argument is that, well, perhaps in that physiological environment, it will culture better and therefore have a greater opportunity to implant than if it had been cultured in the incubator. But the evidence does seem to suggest, though, that culturing them out to blastocyst day 5, day 6, some people even day 7, does yield better pregnancy rates. What symptoms do you look out for? There should not be any symptoms when you have implantation. I know a lot of people talk about an implantation bleed, and it concerns me somewhat because of all the reading that I've ever done, of all the textbooks I've ever read, and even articles that I've read around mid-luteal phase bleeding, it's actually not a reassuring sign to have an implantation bleed. And it certainly is not a sign that increases pregnancy rates. So there shouldn't really be a symptom that you are looking out for. It's not something that you feel or experience when an embryo is implanting into the endometrium. So I don't think there are any symptoms to look out for. Mika Giorgi, ICSI performed 18 eggs off 2 rounds of IVF, second retrieval today, low motility site. See how many types are. Okay, right. So once again, I'm just going to reiterate, I don't really answer individual questions. As far as motility goes, it is an issue. So A and B tends to mean that the sperm is moving in a forward direction, so progressive motility. C means that they're kind of moving but on the spot, which suggests that they're alive. And then immotile sperm, well, you don't know whether they're immotile because the tail doesn't work or if they're immotile because they're dead. So if you're having ICSI, that should overcome the motility issues. And therefore the fertilization should be the same. And that's the point of doing ICSI, is to overcome male factor related issues, of which total motile count is an issue. So if you've got poor motility, then that will affect fertilization. And so that is an indication for ICSI. Best of luck, my friend. I think the next 5 days is really hard. I think it's really important that you keep yourself busy. I think you should make sure you are either working or busying yourself with some sort of task or hobby. And I do think that the 2-week wait is also incredibly trying. I actually think for most patients that it is more trying than the actual 2 weeks of stimulation where you're busy, busy, busy. So sending all the positive juju your way. That's really good evidence-based medicine. Kate Ahrens, is there a success, in inverted commas, rate for PGT normal embryos? What would impact successful implantation of a normal embryo? Oh, this is a great question. And we actually had this discussion at our recent fertility conference around what happens when a normal PGT embryo doesn't implant. Because one would think if everything else is the same, and the reason that an embryo is not implanting is because it's not normal, then if you pick the normal one that's chromosomally normal, then by rights, pregnancy rate should be 100%. But it doesn't actually happen that way. So yes, the pregnancy rates are much increased. Some clinics quote up to sort of 60 to 70%. Using what has been deemed to be a euploid or normal chromosome copy number embryo. But here's the thing that we've learned, is not every PGT platform is the same. There are differences in accuracy rates of PGT. So there is a false positive and a false negative rate. And I think that is a very important question to ask your lab who's performing PGT. What is the chances that the platform that you're using will deem my embryo chromosomally normal when it's actually abnormal? So that would be a false negative, meaning it's deemed normal. So you transfer it and you still don't get pregnant because it was actually chromosomally abnormal. And then what is the risk that the platform deems the embryo chromosomally abnormal when it's actually normal? That's a false positive. So you want to know the platform that your lab is using to test your embryos, what their positive predictive and negative predictive values are. It's an important conversation to have. So that's one thing, that in fact the PGT platform has it wrong. And that's a whole nother conversation. What else could it be? Well, it could be that the embryo is made up of more than just genetics. There are little organelles within it. Mitochondria is one that you would have heard about, that predominantly come from the mum, the egg. And if you have an egg of poor quality, then often the mitochondria are poor as well. And if you don't have a working powerhouse within the egg and then ultimately the embryo just won't continue to develop. So that's the space where all of these supplements have come into being, sort of coenzyme Q10, nicotinamide, NAD, NMN. All of these things are thought to improve mitochondrial health. The jury is absolutely out on this stuff, but it is promising and makes biological sense that this can work. But we're not at the point yet of seeing significant improvements within clinical practice by utilising these supplements. What else could it be? It could be that there's a problem with endometrial receptivity. So there's something else going on at the level of the endometrium. Maybe there's some chronic endometritis. Maybe there is some endometriosis that hasn't been diagnosed. Adenomyosis, there might be a polyp. There could be some endocrine issues. The list goes on. So I think it's really important to understand that there are, and I suppose the other thing to consider too, and this is probably a lesser thing, but there's sometimes embryo transfer technique issues as well. So there's lots of reasons why a chromosomally normal embryo may not implant. And I think it is important for you to just keep that in the back of your mind, that as best as we can, we get the best success rates we can, but they're not 100%. And the big thing from all of this that we learn really quickly in this space is that we're not particularly good reproductively as a species, as an animal, if you like. We're not great at reproduction, and perhaps we should be teaching this as much as we're teaching contraception to adolescents and young adults. We should be teaching about fertility as well. Okay, Yojana Panta. I usually have mild to moderate lower back pain. Could be a sign of endo. Make sure that you have that discussion. Thank you, Legend, from Mrs. English. My pleasure. Gabrielle Santina. What could be some reasons for complete fertilization failure with ICSI? Calcium ionophores are thought to be really important. It is certainly a discussion to have with your embryologist and your physician about what other things could be tried as far as sperm selection techniques and additional chemicals that can assist in fertilization with ICSI, because yes, it is a big problem. I'm sorry that it might have happened to you, but it is one of those things that is often difficult to predict. But have a chat with your scientist about what other options are available for you. My pleasure helping answer your question. Who else? Oh, here's one. Oh gosh, I've missed one. I've missed a couple. Here we go. Mrs. English, lady again, are frozen embryos transfers better than fresh with success rates? Again, it depends very much on the lab where you're having transfers done. We have found at Monash that across the board, we are finding slightly higher success rates with frozen embryo transfers, particularly in natural or low-dose stimulated cycles over artificial cycles. It's a marginal difference. There's lots of different reasons why that might be the case. But yeah, it is important to ask that question of your lab, please. That's an important one. Hello, my friends, to those of you who have joined. Bathina Berry, I love some of these handles. Which weeks are you most likely to miscarry after a successful implantation? So you mean you've got a positive pregnancy test, when are you most likely to miscarry? Well, it's still within the first trimester. So the miscarriage rates do decline as the weeks progress. So anywhere, if you're going to miscarry anywhere before that sort of 8th week, if you have a pregnancy that is, say, chromosomally abnormal, it's most likely to miscarry within that sort of embryogenesis stage, so less than 8 weeks. So you are much more reassured of having an ongoing pregnancy if you see a fetal heart and the growth is good. You're even more likely to have an ongoing pregnancy if you get to that 10th week and your NIPT is normal, and reassuring again if you get to that 12-week scan and everything's looking good. So as time progresses, your miscarriage rates go down. Okay, Melissa, thank you for your feedback, ladies. Melissa Ngoni, does Zoladex increase the endometrium reception of an embryo in an endometriosis patient? Yes, I want to say yes, but obviously endometriosis varies from patient to patient. It is certainly something that I use and many of my colleagues will use if dealing with someone who has, battery low, in someone who has severe endometriosis. We will absolutely consider Zoladex to improve pregnancy rates over a period of time. Brit Zanatic, hello. Is there a standard down regulation timeframe from retrieval to frozen embryo transfer or dependent on the individual? Let me just reread that. Is there a standard down regulation timeframe from retrieval to a frozen embryo transfer? Okay, got your question. So you do an embryo, you do a egg collection, you would inseminate the eggs, you would grow them out to day 5. You've made the decision not to do a transfer, so then you freeze. So from the egg collection, generally speaking, we'll give you about 2 weeks worth of progestogen just to mature the lining so that you can then shed it. I like to have a month break. I believe that it's important for sort of settling down of those huge ovaries. I would prefer to do a low-dose stimulation or natural FET rather than artificial cycle if I can avoid it. And in order to be able to stimulate those enormously swollen ovaries again, they really need to have settled right down. So I like to give just a month normal cycle. Now, if you don't have a normal cycle, then putting you on something like the combined oral contraceptive pill for 3 weeks should be enough to get that lining sorted. You have a withdrawal bleed from that and then can commence an FET. So that's kind of the way that I do it. I think that's sort of the most time effective. I also think that it satisfies what we're looking for with regards to sort of suppressing those ovaries and then allowing a low dose stimulation. So hopefully that's helpful. Curious to know if poor quality eggs could lead to a high grade MB. Of course. I guess it depends on how you define a poor quality egg. That's a really nebulous term, unless somebody's actually said to you have poor quality eggs. But it is quite a difficult thing to determine. It's a subjective call. Someone's saying, hey, your eggs look poor quality, but chromosomally they could be fabulous. Mitochondrial function, they could be fabulous. You could inseminate with a completely normal sperm and bang, you create an embryo that is morphologically fabulous and leads to a pregnancy. So never say never. Oh gosh, the questions are coming thick and fast. I've got two more here that I'm going to answer, and then the others I'm going to ask you to save till next Wednesday, because this is fabulous. This is great, guys, by the way. Jana Panta, what is the normal HCG level at 4 weeks? There isn't a normal level, my friend. We were just discussing today that we have seen, in fact, we're having a bit of a competition between the nurses and the doctors, and somebody has seen a baby when their first HCG was 25. Someone else had a baby when their first HCG was 17. So I don't think that I would be confident enough to put a number on it. I know you guys love your numbers. You love your progesterone numbers. You love your HCG numbers. And I know that's something that you hold on to, but I think it's the progression and change of those numbers that is more important than the absolute number itself. To have any HCG at 4 weeks, let's just hang on to the fact that technically you're pregnant at that stage if you've got HCG. The Finders Collective, come across any funny superstitions you've heard that people do when going through IVF? I love this. I love this question. And in fact, I'm going to be asking this question over the next week or so on my socials, and I want everybody to comment the rituals and superstitions that they undertake. I've heard of lots. I am still like flummoxed over this McDonald's chips thing. I'd never even heard of it until you guys were telling me about it. So I'm very keen to find out where that all started. Somewhere on TikTok, I believe. And why McDonald's chips and not KFC chips? Like, what's the difference? Honestly, is it the salt content? What if I just got them from my local fish and chip shop? Like, would that be the same? Socks, lucky socks. I've seen people lucky socks. Acupuncture at certain times. Yeah, lots of different rituals and superstitions. But yeah, they're some of the ones that kind of front of mind. But honestly, I think it's you guys that need to be telling me what the different superstitions are. Okay, I'm going to leave it there, guys. Thank you so much for contributing tonight. It's been fabulous. I've really enjoyed answering some of these questions, and hopefully it's been helpful for you. Don't forget my question. I have pinned 3 questions to the top of my Instagram feed. I would love for you to comment if you haven't already, and I would love for you to encourage your friends to get on there and comment as well, because I think it's going to be helpful in me helping you guys moving forward. Have a beautiful week. We're back to school next week, and I will see you there. Bye.